just wait. If you could just give us a minute more, we'll just wait for a minute and then we'll start.
Metastatic disease, starting with gemcitabine, then really modified FOLFIRINOX in 2011, followed by gemcitabine and nab-paclitaxel, and in 2016, second-line treatment with 5-fluorouracil with liposomal irinotecan. And then really in 2019, there was a breakthrough where we really targeted precision medicine, where patients were treated with targeted therapy with a PARP inhibitor in patients that had BRCA or BRCA-like mutations. However, even though we feel that we have made tremendous amount of progress, I want to put that in context. In patients with metastatic pancreas cancer, FOLFIRINOX gives you roughly about a 5-month overall survival benefit. This is median. Gemcitabine and nab-paclitaxel, a little over 2 months. NALIRIFOX, which is really liposomal irinotecan with some dose adjustments to a similar triple therapy chemotherapy backbone as modified FOLFIRINOX, also 2 months. So what basically, even though we feel great about these advances, if you're sitting on the other side of the table as a patient or a family member of a patient, these numbers don't really look tremendously exciting. Because of this, what we need to do for, frankly, every single patient is offer them novel therapies in the form of a clinical trial. And these clinical trials need to be specifically designed to target the immunosuppressive pathways or mechanisms used by the pancreas tumor cell to its own growth advantage. And that's what I'll go over. So as I mentioned, the first precision treatment really that came after microsatellite instability, that is only in 1 or 2% of patients with pancreas cancer where immunotherapy is relevant, are patients who have a germline mutation in BRCA1 or BRCA2. This was studied where patients with metastatic disease who had a BRCA or BRCA-like mutation who received 16 weeks of chemotherapy with platinum. So this is either modified FOLFIRINOX or FOLFOX or gemcitabine and cisplatin, who were either stable or had responsive disease for 16 weeks, were randomized on a 3-to-2 ratio with either using a PARP inhibitor or olaparib, 300 milligrams BID or placebo. And as you can see on the bottom left, the progression-free survival favored the olaparib arm compared to the placebo. After this data, the FDA approved olaparib in patients with metastatic disease. Ongoing studies look at also patients who have not germline, but tumor specific mutations in these genes where olaparib or other PARP inhibitors are also effective. So now I'm going to quickly switch to KRAS. KRAS is known by many. It is one of the most common genes that is mutated in cancer. And over the last 3 to 4 decades, KRAS had really been elusive to try and target it. What does it do? It's really a signal transductional molecule. It is usually in the off state bound to GDP, and then is turned on after there's upstream receptor activation, and downstream it engages with the PI3 kinase, RAF and RAL and NF-kappa B pathways, and then RAS is really central in many different cancers, including colorectal, lung, and essential for pancreas cancer practically. If you look at pancreas cancer tumors, over 90% of them have a mutation in KRAS, the most common mutation being KRAS G12D, and then followed by KRAS G12V as in Victor and KRAS G12R as in Robert. Preclinical studies that I don't have time to go over, basically with the conditional knockout and conditional mutations, have shown that KRAS is not just only important in in tumor development, but also in tumor propagation and really survival of the neoplastic cells. Until recently, and again, I'm not going to show you the data which has already been published in New England Journal, and because of that, it's been approved. Adagrasib and others, sotorasib, are targeted molecules that target KRAS G12C mutations, and in lung cancer, colorectal, and pancreas cancer have shown activity and are approved. As an example, what I'm going to be talking about today are upcoming drugs by Revolution Medicine and others. Zoldonrasib is a RAS inhibitor that targets KRAS in the on state. It was a very cleverly designed molecule where it actually binds to cyclophilin A and the KRAS G12 on state, and then this target then is targeted for degradation with the cyclophilin A mechanism. In preclinical studies in KRAS G12D tumor models, impressive response rate and disease control rate. Based on this, the drug went on to a phase 1 clinical trials. And as you can see on the top right, overall response rate of patients who were heavily pretreated, most of the patients had received 2 lines of therapy in advanced setting, showed a response rate of about 30% and a disease control rate of 80%. Looking at a circulating tumor DNA, you can see that the variant allele frequency of KRAS G12D dropped significantly in 100% of decrease in about 39% and greater than 50% decrease in approximately 86%. So zoldonrasib is being advanced in clinical trials in patients specifically with the KRAS G12D mutations in pancreas. Another molecule of great interest is daraxonrasib. This is a Pan-KRAS inhibitor, so it's fascinating. It doesn't really matter whether you have a KRAS mutation, what KRAS mutation you have, or even theoretically in KRAS wild type. We participated in this dose escalation study. The dose expansion was between 160 and 300 milligrams daily. And here, a significant number of patients were treated. Again, most of the patients were heavily pretreated with standard of care chemotherapy. And on the top right, if you look at the best response with daraxonrasib for 300 milligram and for 160 to 300 milligram dose, you can see that a significant number of patients showed tumor shrinkage. Overall response rate in patients with any KRAS G12 mutation was 36%, and a general RAS mutation in 27%. That was in the 300 milligram dose. But if you look at the 160 to 300 milligram, if you combine that, the response rate drops a little bit to 29% in KRAS G12X and 25% in KRAS mutant. Looking at the progression-free survival on the table on the right, you can see median progression-free survival of 8.8 months in the patients that had a KRAS G12 mutation. Just to, we should never do cross-trial comparisons, but just to give you some context, patients with modified FOLFIRINOX and gemcitabine and Abraxane in the pivotal studies had a median for progression-free survival far less than 8.8 months. Looking at the adverse events, because I think that this is what's going to be a little bit challenging to deal with, but there are mechanisms that we are putting in place around it. Fascinating, if you look at the zoldonrasib side effects, not a whole lot of grade 3 side effects. But if you look at RMC-6236, which is the same name as daraxonrasib, you look at the grade 3 side effects, significant rash, diarrhea, mucositis, and nausea and vomiting. And it makes sense a little bit because it's predicted that daraxonrasib which is a Pan-KRAS inhibitor, would also probably affect wild-type RAS, which play an important role clearly in normal cells as well. In contrast, zoldonrasib is something that would only be targeting the KRAS G12D mutation that would be tumor cell specific. So what are here, I just showed you zoldonrasib and daraxonrasib, but here on the left is many different inhibitors, including from Mirati and others that are really targeting KRAS inhibitors. The interesting thing is going to be that we need to already think about the next step. Clearly, these treatments are not leading to a significant proportion of patients who are experiencing a cure. So there's already resistant mechanisms that are being identified. Some of the resistant mechanisms are within KRAS. So if you have a KRAS G12D targeted therapy, there are distinct sites where you will start selecting for mutations, including KRAS, PTEN, and MAG kinase pathway, and including MYC. There's also some metabolic adaptations, epithelial to mesenchymal transition, and hyperactivation of the STAT3 pathway. So as one could imagine, these combinations are being studied heavily preclinically, including many different companies targeting these various different resistant pathways, and then combining also with immune checkpoint blockade, T-cell therapy, vaccine therapy, and other targeted therapies. So I'm going to quickly switch now from targeted therapy to immunotherapy. Pancreas cancer has a tremendous immunosuppressive tumor microenvironment, and unlike other histologies like liver cancer and gastric cancer, unfortunately, pancreas cancer mostly has not really responded to immunotherapy with anti-PD-1 or anti-CTLA-4. Here I'm showing you a randomized phase 2 data by the Canadian group in which they combined gemcitabine and nab-paclitaxel either alone or in combination with durvalumab and tremelimumab, and as you can see, no appreciable benefit. And does that really mean that immunotherapy is not effective at all in pancreas cancer? I don't think so. One of the reasons being is that this was a Nature paper published by Vinod Balachandran's group at Memorial Sloan Kettering, in which what they did was they took patients who underwent tumor resections and then extracted DNA and RNA, and then from the RNA sequences predicted neoantigens, and then from those neoantigens went ahead and custom manufactured an mRNA vaccines. So what happened is that once a vaccine was made, patients at the time post-Whipple surgical resections got 1 dose of atezolizumab, which is an anti-PD-L1 antibody, and received priming doses in combination with atezolizumab of the vaccine, followed by standard of care adjuvant modified FOLFIRINOX, and then received booster vaccines. And in this preliminary clinical trial, there were 16 patients that successfully received the antigens, and as you can see, 8 of them responded to the neoantigens by ELISpot, and 8 of them did not. And then when you look at the recurrence-free survival compared to and compared it to patients who responded versus not, what you found was that patients who had an ELISpot, meaning that ELISpot positivity, meaning that their peripheral T cells were reacting to the neoantigens from the vaccine, those are the patients that did really well. However, patients that did not respond to the vaccine immunologically were at increased risk of recurrence. So this clinical trial is now progressed in a randomized fashion in patients after getting surgical resection in combination with chemotherapy that Columbia is also participating in. So the tumor microenvironment of pancreas cancer is complex. There are many different pro and anti-immunotherapy agents. Cancer-associated fibroblasts release these cytokines that make the tumor microenvironment heavily immunosuppressed. There are many different targets and drugs that are really focused on this, and all of those highlighted or circled or boxed are the ones that Columbia participated in. The two different pathways that I'm going to focus on are the CXCR4 CXCL12 pathway, where cancer-associated fibroblasts release CXCL12 that forms a shield and doesn't allow CD8 T cells to really infiltrate into the tumor, and the other one is the adenosine pathway. So this was work done by myself and collaborators, where we took genetically engineered mice programmed to get pancreas cancer as they have a mutation in KRAS and P53, and we combined chemotherapy with gemcitabine, CXCR4 inhibitor, and anti-PD-1, either alone or in various combinations. And as you can see on the bottom left, chemotherapy with gemcitabine, CXCR4 inhibition, and anti-PD-1 really resulted in a survival benefit. We did a lot of correlative analysis that I don't have time to show you. Once we got this data, I went ahead and wrote an investigator-initiated clinical trial testing this combination in 11 patients. And what we saw was an impressive tumor response rate of 65%. All patients underwent pre-treatment and on-treatment biopsies. And when we look at those patients that had a partial response, we saw that there were increased amount of CD8 positive T cells that came in close proximity to the tumor cells, as did patients in stable disease, but not in patients who did not have a response. Based on this, now there's a large investigator-initiated multi-center study, where Columbia is leading this. Participating sites include Brown, Beth Israel, Medical College of Wisconsin, and Sloan Kettering will soon join. Patients who are treatment naive will be randomized at a 2-to-1 fashion to receive gemcitabine and nab-paclitaxel with or without CXCR4 and anti-PD-1. Another clinical trial that I want to quickly talk about is the adenosine immunosuppressive pathway. Adenosine is released by neoplastic cells, particularly after chemotherapy, and then ATP is released, and then it is metabolized by various extracellular enzyme to adenosine. Adenosine then binds to different receptor on immune cells and is highly immunosuppressive. We participated in this phase 1 clinical trial where we use a drug that targets CD73 in combination with gemcitabine and Abraxane with or without anti-PD-1. In this phase 2 clinical trial, what they found was really that it was gemcitabine, Abraxane, and CD73 inhibition, shown in this purple line in this Kaplan-Meier curve, appear to be significantly better compared to a synthetic control arm. Given this positive result, now there was a randomized phase 3 clinical trial with gemcitabine Abraxane plus minus CD73 inhibition with quemliclustat, which we participated in and just finished enrollment. We also noticed that there were some preclinical data showing that radiation treatment in a breast cancer model system would enhance CD73. And what we predicted was that there is a potential compensatory mechanism where downstream ADORA 2A2B receptors can be upregulated. This was done in collaboration with Anil Rutsky's lab with a talented former postdoc, Dr. Chiarella, in which we took organoids and human organoids from pancreas cancer and treated them with the same drug tested in the clinical trial. At that time, it was known as AB680, targeting CD73. And in all of those organoids, we saw that there was an increase in the downstream ADORA 2A2B receptors. Based on this, we designed a randomized clinical trial led by Columbia, where patients who are going to get SBRT following a modified FOLFIRINOX in a neoadjuvant setting will be randomized to get SBRT in combination with anti-PD-1, either alone or with CD73 and dual dual inhibition with CD73 and ADORA-2A2B. We've passed the safety signal, and right now we are in the randomized arm of the study. The primary endpoint will be CD8 T cell infiltration. Secondary endpoints will be R0 resection, recurrent-free survival, and overall survival. So at Columbia, this is just a flavor of what we are trying to do. A lot of bench to bedside. So on the left, these are the discoveries at Columbia, where scientists identify novel pathways. And on the right, they partner with trialists where we write our own clinical trials to really test these hypotheses to accelerate discovery into impact in oncology, and particularly pancreas cancer. Here is a flowchart of our clinical trial. I'm a firm believer of clinical trials, where I feel that every patient with pancreas cancer should be enrolled into a clinical trial. We have clinical trials in borderline resectable, locally advanced, adjuvant, and multiple lines of therapy in the metastatic setting. Here is our pancreas cross-disciplinary team with multiple surgeons, medical oncologists, advanced endoscopists, radiation oncologists, radiologists, and geneticists, with a very strong team and collaborators of basic scientists who are in the lab trying to identify new pathways that we can interrogate. Lastly, in conclusion, all patients should undergo germline testing and somatic testing, as now target therapies are here. All patients should be considered for pancreas cancer-specific trials if available. Upcoming targeted therapies include KRAS inhibitors. I didn't have time to discuss PRMT5 inhibitors in patients with MTAP loss. Claudin 18.2 has been shown to be, at least initial studies show from China, that it seems to have activity in pancreas cancer. Also GSK3 beta. Immune checkpoint blockade, not effective by itself except for patients who are microsatellite unstable, and CXCR4, CXCL12, and the adenosine immunosuppressive pathways show encouraging preliminary results, as do personalized vaccines. Lastly, I want to thank you for your attention, and I want to acknowledge a multitude of the collaborators without whom, and patients without whom, none of this would be possible. So I thank you for your attention.
Thank you, Professor Manji, for excellent talk. And you gave an insight over the new targets and new molecules which are coming. And also you have shown with your experimental work how the Columbia University has progressed from translated their bench work to the bedside. And that is the way forward. We have to collaborate with the basic scientists. Then only medical science will progress. I think a lot of things are developed in the last 2-3 years for neoadjuvant, for chemotherapy, for borderline resectable, as well as locally advanced. Our second talk will be by Dr. Jaskaran, who looks after our GI, GU, and SPB pancreatic cancers for radiation at our center at Rajiv Gandhi Cancer Institute. So he will be speaking on personalizing radiotherapy in pancreatic cancer for conventional to ablative procedures. Welcome, Dr. Jaskaran.
Thank you, sir, for having me here and introducing me. Well, I look after GI and HPV cancers at Rajiv Gandhi Cancer Institute, and we have a good support from our surgeons, Dr. Shivendra Singh, and the medical oncologist, Dr. Vineet Talwar and Dr. Sumit Goyal. And the topic that I'll be touching upon today is personalizing radiotherapy for pancreatic cancers and how the approach has changed from conventional to ablative over the last few years. So we all know that pancreatic cancer is a therapeutic challenge because of its aggressive early metastasis, which is seen in the course of the disease. Most of the patients present with unresectable disease at the time of diagnosis. And as Dr. Manji just highlighted, that the treatment options are not very great when it comes to unresectable disease. And so hence we have poor 5-year overall survival of around 10%. For a radiation oncologist, the issues that are the primary concerns are the proximity of pancreas to the critical structures like duodenum, stomach, small bowel, and also the movement that we face when we are treating, planning, and delivering radiation to these patients. So when it comes to unresectable cancers, I think systemic control remains the key, but local progression does happen, and it's quite common in these patients and results in pain, jaundice, bleeding, all of these indications where radiation therapy is indicated. So radiation therapy has been, there have been attempts to incorporate radiation therapy into the multimodality treatment in a aim to improve the survival of these patients. It has been tried as an adjuvant approach along with chemotherapy in patients who undergone resection. There have been trials which have shown that addition of radiation to existing standard of cares of chemotherapy like gemcitabine and other drugs have not resulted in any overall survival benefit for these patients, and hence the guidelines recommend that it should not be used. Adjuvant chemoradiation should not be used as a routine and should be only considered in patients who can be selected very carefully after systemic therapy, who have had an R1 resection and who have a node-positive disease. And this also in high-volume centers or clinical trial settings. So as the newer drugs came in, so radiotherapy was tried with them also. There was a FFCD trial which was published in 2008, which concluded that addition of radiation to chemotherapy, that is gemcitabine versus radiation plus 5-FU cisplatin, was associated with worse overall survival due to toxicity and weak systemic therapy. The only trial which showed that there was some modest median overall survival was the ECOG trial published in 2011 with a around 2-month survival benefit for patients, but the trial was limited as it had to be closed early due to poor accrual. Only 74% patients were evaluable, and this overall survival benefit came at the behest of an increased toxicity. So as we moved on in the journey of finding a cure for this deadly disease, it was realized that it is induction chemotherapy which is the approach to go in, and thereafter the patients who are responders and who do not progress can be intensified further with the help of radiotherapy and a combination of chemotherapy. In this regards, 2 trials have shown us the way, which is the LAP-07 trial published in NEGM in 2016, where after an induction gemcitabine and chemotherapy, the patients were randomized to receive chemoradiotherapy, 54 gray along with capecitabine, or continued on chemotherapy. There was no OS benefit. The local control was better, and the patients had a longer treatment-free interval. Similar sentiment was echoed by CONCO 007, who also found that after induction gemcitabine, all FOLFIRINOX, addition of radiation does not lead to any overall survival, although there was a higher rate of R0 resections with chemoradiotherapy in the chemoradiotherapy arm. So what we see is that chemoradiotherapy is improving the local control and getting us better R0 resections, but it is not translating into any survival benefit. So there was a change in the approach to adoption of more hypofractionated radiotherapy in the trials, and there were 2 trials which have shown us the way in this. The first one, which was a positive trial, was the pre-op PANK-1 trial, published initially in 2020 and then updated in 2022, which compared neoadjuvant chemoradiotherapy versus upfront surgery for resectable and borderline resectable pancreatic cancers. And in this trial, it was seen that addition of neoadjuvant treatment had a benefit which was consistent across both resectable and borderline resectable subgroups. And there was a clinically meaningful 5-year overall survival difference in the patients receiving neoadjuvant therapy vis-a-vis surgery followed by chemotherapy. But the limitation of this trial was that by the time this trial came about and was established, the chemotherapy standard arm had moved on from gemcitabine to FOLFIRINOX. So to account for this change, they initiated the pre-op PAN-2 trial. Again, it was a phase 3 multicentric trial in which there were two arms comparing 8 cycles of neoadjuvant FOLFIRINOX followed by surgery, and the other arm was the standard arm of the pre-op PANC-1 trial that was neoadjuvant gemcitabine followed by addition of radiotherapy, hypofractionated radiotherapy and surgery, and then adjuvant gemcitabine. The primary endpoint was overall resection. Recently, about a week back, the group has come out with a full paper, and what they found is that in both the arms, the median overall survival was quite comparable. In the chemotherapy arm, it was 21.9 months, whereas in the chemo RT arm, it was 21.3 months, and this was statistically insignificant. The resection rates were also similar to a tune of 77% in the chemo alone arm and 75% in the chemo RT arm. So the trial, which was actually set out with a view to ascertain whether modified FOLFIRINOX was good enough to give us a good control vis-a-vis doublet of chemo and radiation, did not achieve its target, and chemoradiotherapy still has a role. But quite contrary to this trial, the Alliance group found out that when radiotherapy, hypofractionated radiotherapy was added to modified FOLFIRINOX, it was actually not a good option. Here, the radiotherapy options that was given to the patients were taken up either for SBRT or hypofractionated image-guided radiotherapy, and the trial had to be closed prematurely as the radiotherapy arm could not achieve the R0 resection cutoff mark, and it was closed for futility. So again, the question is whether why are conventional and hypofractionated or the non-ablative radiotherapies, they fall short in locally advanced pancreatic cancers? And the answer to this comes from the radiobiology of the tumor, because this tumor is, the tumor cells in pancreas are quite hypoxic and have a lot of desmoplasia, which gives it radio resistance, which the normal conventional fractionation of radiation is unable to overcome. Also, when we give protracted courses of radiation along with chemotherapy, there is slow reoxygenation and repopulation of the cells, tumor cells. And we all know that when we can compare the ablative doses of radiation, how they work, and the conventional doses do not have any vascular damage or do not have any immunogenic effects on the tumor. So what do we ascertain from them? So we see that conventional chemoradiation along in non-ablative doses, it's safe to deliver, can improve the local control, but the physics and the biology limit their curative potential. And this sets the rationale for dose escalated or ablative radiotherapy, which is possible to deliver today with motion management approaches which are available with the radiation oncologist. So what do we do in ablative radiotherapy? We deliver a very high dose, biologically effective dose to the tumor very precisely in a short overall treatment time. And this helps us achieve durable local control. And why that is possible is because the biological equivalent dose of ablative radiotherapy, when we deliver 50 gray in 5 fractions, or about 60 to 67.5 grays in 15 fractions, or let's say 75 grays in 25 fractions, is close to 100, which is highly tumoricidal. Whereas when we were giving conventional radiation at 1.8 to 2 gray per fraction, the BED that we could achieve was just around 60 gray. This was increased to about 70 to 72 grays when we were doing non-ablative stereotactic treatments, but still truly it was not ablative. So what happens in the tumors when we give such high doses in such a short time is that it gives the tumor lesser opportunity for repopulation and repair. And the high dose per fraction or the ablative doses actually cause vascular damage and immunogenic changes in the cell leading to death, cell death. And we all know that the radiobiology for conventional fractionation works very differently from the ablative doses. The technological advancements which have prompted radiation oncologists to escalate the dose and adopt for ablative fractionations are the availability of motion management techniques like availability of 4D simulators, respiratory gating equipment, tracking, and also the image guidance, which ensures that we are delivering the dose exactly where we intend to be. And there are some new novel radiotherapy equipments like the mRNA, which give us the opportunity to replan on table and deliver each fraction according to the day's anatomy. So just this slide I got to show how much the tumors and anatomy moves in this region of pancreas and upper GI cancers. And these are some of the new gizmos which are at the which are available to the radiation oncologists to help them phase gate their treatment and track the tumors while they are giving their radiation. So are we just talking theory, or do we have any evidence for ablative radiotherapy? I'll just quickly go through the recent ablative radiotherapy papers that have come up. And the first one to come up was in 2021 from the Memorial Group, in which they treated 119 consecutive patients of locally advanced pancreatic cancers from 2016 to 19 with induction chemotherapy, FOLFIRINOX mostly, and some patients got GemNab, and after a median 4-month interval, they were stratified to receive ablative radiotherapy dose 75 gray in 25 fractions or 67.5 gray in 15 fractions. The BED in both of them is almost around 100, and the difference was dependent on how the anatomy was placed in relation to the adjoining OARs. So what they found was that the 1-year overall survival in these patients was around 74%. The 2-year overall survival was around 38%. The median overall survival was 26.8 months from the time of diagnosis. The 2-year local progression was 32.8%. There was just around 8% grade 3 toxicity, mostly GI bleeds, no grade 4 or 5 toxicity. So what they interpreted was that this ablative dose of radiation combined with the standard of care chemotherapies leads to a durable local control and favorable survival in inoperable patients of pancreas, and that it was feasible to deliver dose escalated these ablative doses with the help of motion management and image guidance. And they went on to suggest that it can be a non-surgical curative option for selected group of patients. But this trial was a single center, non-randomized retrospective cohort with a risk of selection bias, and was generally and single institution data is usually less generalizable. So the next trial that I'm going to talk about was a multi-institutional phase 2 trial, which came about, it was published in 2023, and which looked into the safety of delivering ablative radiotherapy doses using adaptive on-table approach with the help of MR system, a 0.35 Tesla MR guided delivery system. The patients, about 136 patients, 57% locally advanced and 43% borderline resectable, were exposed to induction chemotherapy. 65% got FOLFIRINOX, 17% got GemNab Pacli, and subsequently the non-progressors were given the ablative dose of 50 Gay 5 fraction with a daily on-table adaptive replanning. And what they concluded was that the 1-year overall survival for this smart adaptive approach was for the patients was 65%, the local control was 83%, and there was no acute grade 3 GI toxicity that was definitely related to the smart radiotherapy delivery. And hence they concluded that the safety, the primary endpoint was the safety of the delivery, which was achieved, and they demonstrated that it was possible to deliver ablative doses in 5 fractions with MR guidance. But the limitation again was that there is no direct comparator, and there's relatively short follow-up for long-term toxicities and late outcomes. So there's already a phase 3 ongoing trial comparing chemo with chemo plus ablative doses using SMART, and let's wait for that, what it tells us. Another MR-based adaptive planning trial that came about in 2024 from Denmark also confirmed this, that it is feasible to deliver the ablative doses using the MR-Linac systems, and with a good median overall survival of 16.5 months and a resection rate of 21% in this unresectable group, with 67% of those who underwent resection having an R0 resection and having a post-resection median overall survival of 27.7 months. So is it only MR-guided systems that are helping us deliver? So answer to this question came in from this recently published 2025 paper, in which 33 patients, again 20 of which were locally advanced and 13 borderline resectable, were exposed to ablative doses using standard Linacs with the help of 4D CT and the motion management techniques. And it was seen that the radiological resectability was achieved in 84% borderline resectable and 20% locally advanced pancreatic cancer patients, and the freedom from vocal survival was 92.3% at 1 year and about 80% at 2 years, which was quite impressive. So this trial actually shows that to deliver ablative SBRT, one is not limited to MR-Linac centers only, but at the same time, you should have motion management and 4D CT simulators at your behest. So for my younger colleagues, I just compiled these this couple of next slides showing the role of SBRT and how it has been evolving in unresectable and then borderline and resectable cancer patients. So is there any other indication for ablative radiotherapy? Well, yes, it is being tried as a novel non-invasive analgesic approach with for pancreatic cancers, where pain is an issue with patients who are surviving better with the modern day chemotherapies with the help of celiac plexus radiosurgery, as we can see in this 100-patient phase 2 study, where the single shot of 25 gray was given with the help of step-down shells. And it was seen that 53% of the patients had a complete or partial response to pain by 3 weeks. The mean pain score came down by about 3 points between 3 to 6 weeks. There was a significant opioid consumption reductions. The treatment was generally well tolerated. So what the guidelines tell us? Well, they echo the same sentiment that for borderline resectable and resectable pancreatic cancers, radiotherapy as a neoadjuvant setting may lead to an increased likelihood of margin negative resection with local control. Neoadjuvant patients should be ideally inducted after induction chemotherapy, and the doses can be moderately hypofractionated to conventional 45 to 54. But when it comes to locally advanced, we need to up the ante and try to deliver them higher doses in shorter time period. That is, change our approach to ablatives, where we should target a dose of 50 gray in 5 fractions, or hypofractionated adaptive radiotherapy regimens like 67.5 gray in 50 fractions. So all these things have actually being extensively investigated all around the world. And so we have a dedicated session on ablative radiotherapy in ASTRO 2025 on GI cancers and pancreatic cancers. So I'll just take you through a couple of cases that we've done at our center. This was a 70-year-old lady presenting with a locally advanced body of pancreas cancer, and she received 4 cycles of FOLFIRINOX, and after that was taken up for conventional radiotherapy along with capecitabine, 50 gray in 28 fractions, and thereafter underwent resection. I thank Dr. Shivendra for giving me these surgical slides. The post-resection histopathology report showed that the tumor was YPT2N1. Another patient, and again a middle-aged gentleman, presented with locally advanced pancreatic cancer of head and body, received 6 cycles of FOLFIRINOX, was subjected to SBRT 35 gray with a TBI boost, and was able to undergo surgery, again Whipple's surgery with vascular divestment, and the histopath, final histopath was YPT2N0. These are his operative pictures. Another gentleman, 58-year-old man, locally advanced pancreatic cancers, neck and proximal body, 4 cycles of FOLFIRINOX, given 30 gray 5 fractions of radiotherapy, went on to receive 5 more cycles of FOLFIRINOX and was able to undergo surgery. And the final biopsy report was no evidence of tumor. So I just bring to you our 1-year analysis, initial analysis of 23 patients whom we given SBRT at our center, with 18 of them being included for final analysis. 5 of these were borderline resectable and 13 locally advanced. At the outset, 80%, that is 4 out of 5, we were able to do resections, and 3 out of the 13, that is 23.7%, underwent resections in the locally advanced pancreatic cancers. With that, I'd like to end my presentation, and thank you very much for your patience.
Thank you, Jaskaran, for covering complete spectrum of radiation and your experience. And I think we'll move on from this to the next talk by Professor Manish, who is a close friend of mine, and he will be exposing on the role of surgery in borderline resectable and LAPC. As you know, everything for neoadjuvant chemotherapy and neoadjuvant radiation all are directed towards achieving R0 resection. I think Manish will show what is the data from TMH, which is the largest, highest volume center for pancreatic cancer in India. Welcome, Professor Manish.
Thank you, Dr. Shivendra, and thank you, the organizing team, for asking me to speak. We have had a couple of wonderful talks on how precision medicine is important and how ablative radiation is also picking up, especially in unresectable scenario. And the brief given me today to talk on is about the evolving role of surgery in borderline resectable and locally advanced pancreatic cancers. So quickly, if we look at the history in the early 20th century, what we used to see was the resection rates were very low, and the 5-year survival was dismal. It was not more than 5% or at best 10%. And when the resection rates were so low, even the mortality out of these resections was very high, in the range of 20 to 40%. And that culminated into an overall poor outcome in pancreatic cancer. But later on in the 20th century end, what changed was there was specialization, there was centralization, which in turn led to improved techniques, standardization, and then that led to a safe surgery. And then that surgery also improved, the radicality also improved, the R0 resection importance was identified, the techniques for doing better R0 clearances, the artery-first approaches, the extended resections, multivisceral resections, all of them were devised, and yet the surgery became safer with a 5-year with the perioperative mortality under 5%. And this I would say was a turning point in terms of management of PDACs per se. because this led to an improvement in 5-year survival of more than 30% of treated pancreatic cancer, which was never seen before. Now, broadly, we know this that the disease is categorized into resectable, borderline resectable, and locally advanced disease. And this classification is a radiological or anatomical classification based on the vessels involved, namely the arteries, which is superior mesenteric artery, celiac axis, or common hepatic artery, and the veins, which are superior mesenteric and portal vein. Now, if I have to simplify this, the venous involvement, majority of the venous involvements are called as borderline resectable diseases, and majority of the arterial involvements would fall into a locally advanced category, which were earlier defined as unresectable disease. But this is the anatomical classification, as I said, but there is more to it. When we plan treatments, the treatment is not purely now dependent on the CT scan or the anatomical criteria, but also based on the biochemical factors, which is most importantly the CA19-9 level, which has been the most important clinical biomarker for PDAC treatment, which guides treatment, which prognosticates well, and also the conditional or the performance status, which also dictates whether a major radical chemotherapy or a radiation or a major surgery will be undertaken for a particular patient. So taking into these three factors, clinical decisions are made and suitable patients are directed towards more radical or curative options. Now, the other thing that we can look into is the important randomized trials which have taken place for PDACs, and they have been for adjuvant approaches to begin with, then neoadjuvant, palliative therapies in metastatic and locally advanced settings, and some of the important trials where as regards to borderline resectable disease have already been discussed by Dr. Jaskiran, but I will just briefly touch upon them since I will be talking on borderline resectable and locally advanced disease. Is the PREOPANC trial. The first PREOPANC trial did not show any difference when preoperative chemoradiation was used versus resection was used. The initial results were negative, but the long-term results did show survival advantage of using a neoadjuvant approach. However, that survival difference was modest by only 1.5 months, but it was statistically significant. Then the recently, just the last week, PREOPANC-2, which got published, which compared FOLFIRINOX and gemcitabine-based chemoradiation, and it showed that both the approaches are comparable. The median survival is comparable when both approaches have been used. And what we knew before this was from the ISPAC-5 and the Alliance trial is that the best approach would be a modified FOLFIRINOX across these in both of these trials, which has also got confirmed in the PREOPANC-2, and the alternative approach could be a gemcitabine-based radiation therapy, all leading to similar outcomes. What all these trials also showed was that maybe the survival advantage was not there, or to best was modest. But what all these trials have shown consistently is that when neoadjuvant approach is used, the R0 resection rate is significantly better. Whether this would translate sometime into a long-term survival is something that we have to wait and see, but at least the R0 resection rates are better. Of course, the downside of using a neoadjuvant approach is that the overall resection rate goes down because there are dropouts on neoadjuvant therapy. This therapy is not an easy therapy. It's quite tough. The risk of progression as well as the risk of dropout related to the complications are also high. And although these therapies have become better, but we need to have better tolerated regimes devised for patients with PDAC. So that was about evidence in borderline resectable disease. When we look at the locally advanced diseases, a neoadjuvant approach used for surgery, there are no randomized trials in this setting, simply because we do know that there are a number of patients, selected group of patients, which can be carved out from a locally advanced group who respond well to neoadjuvant approach or maybe an initial palliative approach, and then can be converted into surgery. And there is some data to show that there is advantage of using surgery as an approach in responding patients with locally advanced disease, that is with arterial involvement. So majority of the data that we have is retrospective data or propensity matched data. This is the data from large data from Korea, where again they have shown that locally advanced disease, when they undergo resection, the survival is significantly higher, 56 months versus 21 months. Of course, these are better selected patients, but when you do selection right, you can have this kind of a median survival even in locally advanced disease. Similar reports from the consensus statement from Japan. Again, what they mentioned was the median survival again after surgery in converted patients. The term used here is convergent surgery. That means initial therapy, and then you convert the locally advanced disease patients into a resectable group, and then offer surgery. When we do that, the 5-year survival or the median survival can be between 20 to 40 months. And what has been recommended here in this guideline is that at least a 4 to 8 months of neoadjuvant therapy, predominantly chemotherapy, should be used minimum before proceeding to resection. And again, this is another recent data again coming from Japan. Overall, the conversion rate after neoadjuvant therapy in locally advanced pancreatic cancer can be in the range of 20% to 25%. And what is again coming out from these data is that a minimum duration of 6 months of preoperative therapy is essential, and FOLFIRINOX-based regimens do work the best in this kind of a scenario. And when we operate, the best possible outcomes for locally advanced disease can also be achieved. Coming now to the technique, again, as surgeons, what we aim at always, whether it's resectable, borderline resectable, or locally advanced disease, the aim is always to get an R0 resection. And R0 resection means that more than 1 millimeters of margin. And when we achieve, we have enough data to say that that's the best possible surgery. Anything less than that is going to be inferior. So in order to achieve this, as surgeons, we have different techniques, namely the Artery-First approach, the triangle clearance, which is more recently defined, which is nothing but clearing the tissue between the celiac axis and superior mesenteric artery origin. And then when we have borderline resectable or locally advanced disease, we need to do an en bloc resection along with vascular resections and techniques such as divestment procedures as well. So there are 6 different SMA first techniques which have been defined, and the use of these techniques, as you see in the right picture, can be dependent on the site of the tumor, whether it's in the uncinate process, whether it's in the head region, whether it's at the neck area or towards the body tail region. Depending on that, different approaches to SMA can be used. And the principle is that we identify and dissect the superior mesenteric artery rather than dissecting tumor out of the artery. That gives us the R0 clearance. And what commonly used approach is the right medial approach and a posterior approach to SMA first, as it was shown as a standardized technique in this video. But again, depending on the site of tumor, we can have different approaches which can be used. The vein resections, the ISGPS defines, again, depending on the degree of involvement of vein, the site of involvement of the vein, suprasplenic, infrasplenic, if the splenoportal confluence is involved, and the amount of resection of the vein wall required and the type of reconstruction which is required. That is how the ISGPS types have been classified. So basically, if there is a lateral wall involvement and a small excision with a primary closure is done, that is called as a type 1 portal vein resection. If we have a larger area of the circumference resected, which requires a reconstruction by either a peritoneal patch or a synthetic graft, as you see here as in the second image, that is called as a type 2 portal vein resection. Type 3 is nothing but an end-to-end vein resection. A segment of vein is resected, typically of about 3 to 3.5 centimeters. Up to that length, it is manageable by an end-to-end reconstruction. More than that, it becomes difficult. And if the length loss of vein is more than that, then a graft needs to be placed, interposition graft needs to be placed to join the two ends together, which is nothing but a type 4 portal vein resection. Coming to the artery section, the majority of the evidence is, and the majority of the surgeries that are performed with artery resection are for body tail tumors, typically when the common hepatic artery, splenic artery, and the celiac axis is involved. In this type of a scenario, an Appleby procedure is performed where the hepatic artery is divided proximal to the GDA. The GDA is being preserved, and then the celiac axis is resected along with distal pancreas resection, by which the blood flow is then reversed from superior mesenteric artery through the GDA, and that supplies common hepatic artery, which is the principal. But the prerequisite is that the gastroduodenal artery should be intact, as you see in the first picture, which is an classical Appleby procedure where there is no need of a reconstruction of vessel because the GDA is intact. But if you have tumors which are going towards the gastroduodenal artery or distally involving the common hepatic artery or up to the bifurcation, then the resections would obviously require a reconstruction either by a synthetic graft, or we can use native tissues, the saphenous vein, or sometimes the splenic artery segment can be used to reconstruct between the celiac axis origin and hepatic artery. So this is just to show that these resections are being attempted with more and more advanced diseases. Initially, it was only reserved for the so-called class 1 tumors where the GDA is intact. But now with the advent of good neoadjuvant approach and responding patients, the anatomical factors have become less important when we are planning curative resections because technical feasibility has expanded. So then if the GDA is involved, we still can go ahead. If the combined vascular involvement is present, still this can be attempted, although the cases would be rare and very, very highly selected. But this is what defines as a classification of celiac axis involvement in today's time. If we look at the outcomes, again, we do not have any randomized data, but the major data which comes from the Mayo Clinic and from Korea, which states that after neoadjuvant approach, the outcomes are quite encouraging for celiac axis resection, and that is why this remains the most commonly performed arterial resection for advanced pancreatic cancers. Apart from the celiac axis resection, we can require a hepatic artery resection, which is similar to how a celiac axis would be resected, but there would be always a need for a reconstruction. And then we can have tumors which are at the uncinate, where SMA resection may be required with either an end-to-end anastomosis, or you may require a longer length with a synthetic graft placement in between. But the SMA resections remain a challenge. Again, if we look at evidence for common hepatic artery and hepatic artery proper, similar to the celiac axis resections, we have good outcomes which are reported when the case selection has been good. But when it comes to the SMA resections, the perioperative morbidity and mortality continues to remain high, and that is why it is definitely the indications and the performance of a SMA resection remains questionable, and we need more data or more evidence to support this. Until this surgery becomes more safer and patient friendly, this should not be attempted. Now, because the SMA, resecting the SMA is a problem because of the morbidity being very high, and because also the observation that not always the disease around superior mesenteric artery, as you see here in this picture, is infiltrating the vessel wall. The techniques defined as the periarterial divestment techniques have been devised, which is nothing but peeling off all the tissue around the artery without resecting the vessel wall, but entire neurolymphatic tissue around the artery can be excised and yet an R0 resection can be achieved. As you see in this image, the disease was very much abutting, maybe more than 180 degrees, but you can still achieve a periarterial dissection and remove the tumor. Now, sometimes the involvement is slightly more, where the adventitia of the artery is also involved. Typically, you will have to be always prepared for doing an artery resection in this, but sometimes we can also get away by doing a subadventitial dissection, which is a defined terminology, which is also part of a divestment procedure. So this is more safe than the SMA resection, but we will have to be, of course, very careful as well while doing these surgeries, because the risk of morbidity can still be high. Now, if we combine all the data for resections of borderline disease and locally advanced disease, what we see globally is that the mortality has reduced significantly. The R0 resection rate has improved, which is more than 70% now. And with the 5-year survival, which was not existent before, is now in the range of 15 to 20%, which itself, I would say, is an achievement. So the indications have to be proper, and we should understand that um, what is locally advanced is not necessarily a very advanced stage, but we should also understand that clinically localized disease is again not exactly equal to a biologically localized disease. Where I give you these two examples, where the first case where there is a neoadjuvant approach utilized, radiation therapy given, CA19-9 showing a good response, and then there is a complete resection achieved, but there is a early recurrence and the patient did not do well more than 1 year. As against another case where there is similar line of treatment which is being used, R0 resection is achieved, but then the patient continues to do well 5 years down the line post-resection. So indeed, pancreatic cancer remains a heterogeneous disease, and uh, what is biologically responding and localized is not very well understood. So these remains the areas of controversies as to which patients would benefit the most from these kind of conversion surgeries. Are arterial resections really going to be beneficial, especially the SMA resections? This is a debate, and the role of radiation therapy in locally advanced pancreatic cancer is still unsettled, especially when it comes to using it in the neoadjuvant setting. As Professor Gulam also mentioned before, these are some things which we are going to look at for future as to how we can better predict which patients would benefit the most by curative and radical surgeries and other therapies. And these are some of the avenues that we are looking at, and we hope that we find some answers in near future. Coming to our experience quickly to share that we have a high volume center for pancreatic resections at Tata Memorial Center, both at TMH and at ACTREC. The data relevant to today's topic, that is borderline resectable disease, this is some of our work, which again highlights the importance of neoadjuvant approach in borderline resectable diseases. There is definitely a benefit of using it. When it comes to portal vein resections, this is again our Indian multicentric data, where we have shown that there is a 25 months of median overall survival, especially, and these are mixed cases where upfront surgery or neoadjuvant approach was used. And the two of the most important factors which we found out was the therapy completion rate and the R0 resection rates. If these two are in place, then the patients enjoy the best survival in this scenario. And similar to that, in the locally advanced diseases where we do an extended multivisceral vascular arterial resections, again choosing the cases appropriately, and biologically good responders are the ones which do the best when we do these radical treatments. So towards my concluding part of my lecture, what I would highlight again here is that you see on the left the resectable disease, ECOG1. This is the recommendation today, is resection followed by adjuvant. Of course, the approach is also changing now, where neoadjuvant approach is also used in resectable tumors. and the survival you see is 26 months. But when you have a borderline resectable or locally advanced disease, you do neoadjuvant therapy, you get a stable disease or you get a response, you explore these patients, you resect these patients, and again, you have the same outcome as you would have it in resectable tumors. So there is definite chance of converting these borderline resectable and locally advanced tumors also towards similar outcomes to the initially resectable tumors which present to us. So surgery remains at present in the center for offering the cure. And what has changed or the best outcomes that we know today are because of neoadjuvant approaches, multidisciplinary approaches, and improvements in the radicality and safety of surgery. The concept of locally advanced or borderline resectable diseases are no longer static, but they are dynamic based on the response to therapy, based on the technical feasibility of reconstructing, and based on the conditional factors of patients, whether a radical treatment, whether a patient would recover well from this kind of a radical treatment. So this is where I would conclude. Yes, of course, biology remains king, that we always must remember. But when we are talking in context of borderline resectable and locally advanced disease, we must also understand that biology is not equal to vascular involvement, not all the times. Sometimes it does that is synonymous, but not always. If there is a vascular involvement, the tumor is biologically bad. This is what we need to understand. And that is why in good responding patients, the resection should always remain an option. Thank you very much for your kind attention.
Thank you, Manish, for excellent talk. And again, you highlighting that the biology is the king. Only thing is how to assess that biology pre-operatively or pre-treatment. Other than CA19-9, are there anything that you are using or Dr. Maji is using at their center for pre-operative? All patients, NGS we don't do at our place because of the cost constraints and resource constraints. But other things that Manish you are using at your center and Dr. Manji also.
So we do heavily rely on CA19-9, but also we are in a process of exploring ctDNA. I'm sure many other centers are also looking at ctDNA as a potential marker in this scenario. But I would also love to hear from Professor Manji.
Professor Manji.
Yeah, no,
Yeah.
yeah. No, so I think that over here, unfortunately, there are no good really biomarkers, right? So to predict which patients are going to be truly cured, right? The way that I really see this is that pancreas cancer is stage 4 disease until proven otherwise. We talk about recurrence, but it's not really recurrence. The tumor, micrometastatic disease was already there. It's just that we could not radiologically detect it. So that's the reason why many centers are going towards a neoadjuvant approach. And really that is to downstage a tumor, but at the same time, I think that it's the duration of time of giving neoadjuvant chemotherapy. You're really selecting for the good biology patients, right? So if they did not progress during that time, it just tells you that those are the patients that potentially should go for surgery. So currently we use CA19-9 as your center does. If it's over 1,000, we're a little bit hesitant, but at the same time, we want to make sure that that elevated tumor marker is not in the setting of biliary obstruction, which can artificially also increase CA19-9. Just like you, we are waiting for better and better systemic treatments such as KRAS inhibitors. In the neoadjuvant setting, there's going to be a clinical trial that is being already planned in the adjuvant setting, right, to try and improve outcomes.
Professor Manji, as you do NGS in all your patients, so what is the incidence that you get a good targetable drug available in those patients? How many percentage of patients you get?
So we do germline tests. Yeah, so we do germline testing in really over 80%. We are attempting to do it in all patients. And the NGS in locally advanced patients, sometimes with US-guided FNAs or those biopsies, sometimes we don't get adequate tissue. So we also get circulating NGS for those Guardant or equivalent or Foundation one, where we can get mutation analysis. Before, we were not doing it as much because what are you going to do with that information, right? But now that we have KRAS targeted trials, and there are many of them, we really want to know the KRAS mutation that the patient has.
Thank you. Are there any questions from the audience or participants?
So we had some questions in the chat by Ramneek Kaur. There's some 2 questions.
Dr. Jaskara, there's one question: how to select SBRT versus conventional RT in unresectable pancreatic cancer post NSCT?
Oh, well, that's a very practical question and a good question. Usually at our center, we would select for radiation only after doing induction chemotherapy and doing a rescan, triple phase CT scan, and then having a surgical review to see whether the patient is resectable or unresectable. That means conversion is possible or it is still unresectable. And after having those inputs, we would assess the size of the tumor, the proximity to the organs at risk, and then decide whether we would like to go for SBRT or we would like to go for the fractionated radiotherapy. Another point I would like to enumerate here is that it also depends upon the ease of the surgeon. Many times surgeons are not very comfortable with a long treatment or the ablative radiation doses, but I think in tumors less than 4 centimeters, where we are looking for conversion surgery, SBRT should be attempted. Otherwise, conventional radiotherapy along with or hyperfractionated adaptive radiotherapy approach is also something that one can ponder upon.
Manish, there's one question: how to select patient for systemic chemotherapy alone or chemoradiation for borderline resectable or locally advanced? What is your preference? And the same, what is Professor Manji's approach for these patients? Chemotherapy or chemoradiation, both?
So what we do at our center is that we begin with chemotherapy alone. That's the standard approach. And at the end of the general regime used is FOLFIRINOX if patient is fit, otherwise gemcitabine, nab-paclitaxel. And at the end of 4 cycles, we do have an assessment. If we are on a path of good response, we would continue with chemotherapy alone and not prefer radiation in that scenario. Only if we are not achieving a good response, then we add radiation in this scenario. And then, of course, if the intent is neoadjuvant, it's the standard dose or SBRT. But if the intention is not for surgery, unresectable extreme of locally advanced disease, then we do advocate for ablative RT as well.
So even for locally advanced, you prefer chemotherapy alone for locally advanced?
Chemotherapy alone, yes.
Professor Manji, your opinion?
Yeah, same. I really think that we should very rarely do we consider chemo RT or RT alone. Those are patients who probably it's more in the palliative setting where they're not candidates for systemic chemotherapy or really for surgery as well, where we're trying to just palliate the primary tumor, more for pain, not really unlikely for curative intent, but to give them treatment-free time for quality of life. But I also prefer modified FOLFIRINOX first, and then move on from there.
Our approach has been for locally advanced, we prefer giving radiation. Once we get a good response by FOLFIRINOX, we give radiation by SBRT, and then continue again 4 cycles. So have a good R0 and clearance from the arteries. That has been our approach.
Yeah, similar.
So, Dr. Jaskar, there's one question, whether you prefer CyberKnife or IGRT?
Well, CyberKnife's availability is not very much in India. And without CyberKnife also, with the help of good 4D CD simulator and gating, it's possible to deliver good doses. So it's actually a no choice. There's nothing to choose between them. One problem that we usually face with CyberKnife is that tracking is a little more cumbersome in CyberKnife without a fiducial, which our interventional radiologists find it difficult to place in the retroperitoneal space.
Next question was the same. How do you like to place your fiducials, EUS or CT guided? And where you
We've been requesting our interventional radiologists for a time, but we're slowly moving to getting support from our gastroenterologists also in EUS guided approach.
And what is it? Manish, you have been using CT guided or EUS guided fiducial placement?
It is CT guided, not EUS guided, even for us.
But Dr. Manish, are your interventional radiologists comfortable in putting a fiducial?
So that is again not very common practice, but whenever we have used it, it is through CT scan guidance and not from EUS guidance. Again, from the same point of view, the risk of inducing a pancreatitis or causing a bleed, they are concerns.
So this is the reason why I feel that with a good motion management capability, giving it without tracking, fiducial tracking is feasible in most of the LINACs.
Yeah.
Thank you. I think there are no questions. So I'd like to thank all the speakers and especially Professor Manji for sparing his time in the early morning to spare his thoughts and experience with us.
No, this is great. Thank you for having me, and happy to look forward to collaboration, etc.
Definitely. Thank you, everyone.
Thank you, sir.
Thank you, everyone, for your time. Thank you so much.
Thank you.
Thank you, everyone.
Thank you. Thank you. Bye-bye.
Thank you.